Hello everyone, and welcome to Health Law Talk presented by Shahardy Sherman Williams. Before we get started, please be sure to subscribe to our podcast and follow us on Facebook, Twitter, LinkedIn, and YouTube, linked in the description below. We hope you enjoy this episode.
All right, good morning everyone. Conrad Meyer here for another edition of Health Law Talks here at Shahardy Sherman Williams with Rory Berlina. And Rory, say hello, good morning.
Good morning, everyone.
And today, everyone, we have a special guest with us today, Keith Hustak. He is the Vice President of Advanced Provider Practice and Vice President of Operations for Spectrum Health. And he's on the line with us today. Keith, how you there? You there?
Yes, good morning. Thanks for having me.
Great. Today we're going to talk about something that that all of us have dealt with, and especially Keith, with respect to advanced provider practice, APRNs, physician assistants, and that deals with Incident 2 billing requirements. And a lot of you are going to scratch your head and say, what? What Incident 2? What is that? And it's actually a very, very important topic because Incident 2 is if done properly and if in compliance, can help practices and large groups capture additional revenue from Medicare. If done wrong, you have a real problem with potentially opening up your practice, your group, to a False Claims Act, as well as civil monetary penalties. So a lot of times people scratch their head and say, well, I don't even know what that means. What is Incident 2? So today, we with Keith on the phone and Rory and I, we're going to explore the world of Incident 2. So with that being said, we're going to jump right in. Today, when you look at Incident 2, Keith, what's your understanding of why Incident 2 would be important to a large group like Spectrum?
Yeah, Incident 2 is it's critical to understand the details, because if you don't get the details right, you could be then accused of false billing practices. And, I think when I speak across the country, providers, physicians, APPs, PAs, APRNs, I think that the traditional, and I don't have any data on this, but I think the traditional provider really doesn't understand the details of Incident 2 very well, and that puts us all at risk.
So let's
that's why it's important.
So let's jump back. What is it? I mean, that's like it's sort of like the 1,000-pound elephant in the room. What is it?
Yep.
So go ahead, Keith. What's your understanding? What is Incident 2? How would you, in a layman's terms, how would you describe Incident 2?
Yeah. So here's how I describe Incident 2, and we give a capture the moment lecture at Spectrum really to teach providers this. But Incident 2, the way I teach it is this. Incident 2 starts at a second visit, a subsequent visit after a physician has seen a patient and has established a plan of care for that patient. Mm-hmm. And I'll give an example of this. So the classic example is, a physician sees a patient who has hypertension. Mm-hmm. And that physician says, okay, we're going to start you on this blood pressure medication. I'm going to have you follow up with your, with my APP in 6 weeks. And we're going to see how that blood pressure medication is doing and how you're doing. Incident 2 then starts, the possibility of Incident 2 starts at that subsequent visit. So at that subsequent visit, the PA sees the patient and notices what the physician's plan of care was. If the PA or the APRN is seeing that patient and says, okay, I see the plan of care here, patient's doing well on this blood pressure medication, and follows that plan of care that was established previously by the physician, and doesn't change the plan of care, doesn't see any new diagnoses, and here's kind of you can't make this stuff up.
Right.
The key to it is that a physician who is working in that same group has to be in the office at that time. If all that criteria is met, then they can bill Incident 2, and what that essentially means is Incident 2 the physician, and can get 100% of the service, almost as if you're billing like under the physician, essentially. And that's what Incident 2 is. I always teach that Incident 2 really is an outpatient follow-up visit term. It's also a CMS term, meaning that a lot of like commercial payers, in fact, they don't really deal with incident two. Like here in our market in Michigan, some of our payers don't credential APPs. And because they don't credential APPs, we don't really even have to deal with it on the commercial side. So again, outpatient, CMS term, follow-up visit, a physician, not the physician who saw the patient, by the way, but a physician needs to be in the office at that subsequent visit. If all that criteria is met and you don't change the plan of care, you can bill incident two. It's that simple.
So just so everyone understands, Keith, you manage just a few APPs, right? How many? 700. 700.
We have 700 APPs in our system.
That is we have a lot. That's a lot of APPs. Yeah. Well, and you're right. So the difference is from what you're saying. The reason incident two is important from all the compliance methodologies you just stated. But the difference is if you bill incident two, you get 100% reimbursement versus 85% reimbursement. So it's really a delta of 15% from Medicare with respect to the incident two. Is that right?
That's correct.
Okay.
That's correct.
And that 15% could be a lot over time.
It can be, yes. And I think we'll get into it, but there's really pros and cons to really focusing on that incident two, that extra 15%, which we can get into.
And that's the nuances of incident two and sort of the pitfalls, right? I mean, you have to really watch yourself. So, for example, in the example that you gave with the PA following up on the blood pressure medication, basically, if the PA does not follow the initial plan of care, let's say that PA says, well, I don't like blood pressure medication. I'm just going to DC it, and we're going to start something new. Can that PA then bill incident two on the claim form as if the physician had done that change? And
it is of my opinion that would be extremely risky, and therefore no,
right.
That should not be done.
Because under the Medicare benefit manual, it states that you need to follow the plan of care that was initially established by that physician. And I guess the thought behind that would be that meaning I guess from a quality standpoint, they don't want APPs to sort of decide to go rogue, I guess, if you will, right? And without having the physician having a little bit of oversight with respect to that patient.
Yeah, I mean that's. I think we could theorize as to why they have these crazy kind of rules and regulations, but that probably has something to do with it when this law was established back in the day. Absolutely.
Yeah, and I think when you look at it, when you sort of get in the weeds. And you look at the way healthcare delivery was started. I mean, back in the 60s and the 70s, I mean, you would have a lot of solo practices that you had a lot of nurses and you had a lot of even spouses helping out the physician, take blood pressure, help intake and so forth. And then as we evolve to present day, now you have a tremendous amount of multidisciplinary teams. You've got PT, OT, you've got APPs, like your mid-levels like you're talking about. And so you're looking at a lot of different, specialties working toward the same goal that are integrally a part of that patient care. So now with incident two, if you decided to put your toe in the water, right? If you wanted to do that, you have to be cognizant of the compliant issues with respect of the direct supervision. Now, interestingly, there's been a lot of comment over the years on incident two and that I've seen in the federal regs. And basically, the comment was, "What is direct supervision?" And Keith, did y'all get into that in Spectrum, or was that ever a discussion about what was or how do we define direct supervision?
Yeah, we do get into that. Like in my lecture, we talk about direct supervision and generalized supervision and whether or not you have to be in the building or out of the building. Just to be transparent, we ended up deciding to, because of what we just talked about, how difficult incident two billing is, we decided as a system to go away from incident two, to not even bother ourselves with it. Because yes, that 15% over time can make up, can bring in a lot more revenue, but the risks of it and all the things that you have to kind of, cross the T's and dot the I's on, it just wasn't worth the 15% in our opinion.
Right.
So that's kind of why we decided that, we should probably go away from incident two altogether. Now we still do split shared on the inpatient side. We do think there is a great value there on split shared, which is very similar, but still a different term. But we decided to go against incident two.
And I understand that, and you're correct. I mean, following the compliance, with respect to the incident two, and let's break that down. So to bill incident two, you're going to have to have direct supervision. You're going to have a service that is, or supply that is provided as an incidental part of the physician practice by auxiliary personnel. Now that could be APPs, it could be PT, OT, and direct supervision, like you were alluding to a moment ago, requires the physician to be immediately available in the practice. Okay, and that could be if it's a group practice, it could be another physician in that group. But it doesn't mean that the physician is down the hall. It doesn't mean that they're in another suite. It doesn't mean that they're on another floor. They need to be immediately available to help that auxiliary personnel with the patient. Otherwise, if you don't meet, like you said, all that criteria, then you're not going to be able to do it. Now, interestingly, on the claim form, when you submit the claim to Medicare, or really your fiscal intermediary, right, it's going to have the physician's NPI number. It's not going to have the APPs. It's not going to have the PT or the OT. Now, it's just going to have the physician because, of course, if you meet those requirements, then it's as if the physician had done the service him or herself. So that's in a nutshell. That's incident two. And you're correct about the pitfalls, Keith. I mean, I gave a good example at one of my speeches about an orthopedic group that I represented that literally had multiple satellite offices, and for a period of 3 years or more had sent their APPs out to the satellite offices to do E&M visits on patients with no physicians in that satellite office. So you can imagine when we sat down and we did an audit and we found this out, I was like, whoa.
Right.
We have Houston, we have a problem.
Right.
I mean, we have a False Claim Act, for sure, a false FCA issue, for these overpayments. And initially we had to decide what route we're going to take. So, in terms of how do we repay the government, right?
Right.
And that involved an internal investigation and involved, let's see where the problem was. How big is the problem, and what are our options in terms of using the self-disclosure protocol? Do we simply just return to the MAC? The delta between the 100 and 85%. And ultimately what we did, we just did the delta because what we were seeing before was we would have to refund all of those claims. So imagine the damage to operating capital, right? If you had to refund 3 years of claims for those satellite offices and then rebill them. So
absolutely.
I mean, it is good.
I was just going to say, I think again, across the country, when I talk to my peers, colleagues, I think the biggest misnomer is people think you can bill incident two simply by seeing the patient and sending the note to the doctor to sign off and say, yep, I agree with the plan of care. And people think, okay, I can bill incident two. And that is not incident two. And I think in that case you just talked about, where you get these like satellite camps now that are pretty big in healthcare, right?
Right.
They send the APP out, and again they think, we can send, and I don't know if this happened in your case, but we can just send the notes all the physician, they sign off for a test,
right?
And that's incident two, and that quite frankly is not anywhere near incident two billing.
That's exactly what happened. So when we looked at the medical records and we saw the attestation. And immediately I said, okay, well, Dr. John Doe, were you at this satellite office on this date and this time?
Yeah.
And the answer was, well, no. And I said, let's do the really honest thing here. Everyone give me your calendars. And then let's reconcile it with the dates that you said you attest to on those records. And all of them were wrong. And so when we saw that we did an extrapolation of 30 days, we realized, okay, we have a bigger problem here. So,
that's right.
It really was a pitfall. So let me bring this other question to you, and what happens if you're say you're a group practice and you're doing incident 2 billing, because you want to capture the 15%, the 100%, but you're paying your mid-levels on production. How? Ooh. Do you see the problem there? So how? Because the claim form has the NPI of the physician, I don't know of a way to track production. So, if that's the case, have y'all ever heard of that? Just curious if that's ever crossed your mind on a comp model on a different side, if you're paying your APPs on a production base.
Yes, huge issue across the nation in APP world. I think every conference I go to, there is somebody who is either speaking about this or is raising the concern of how do we drive performance out of APPs, but yet give them credit when credit is due. And so there are certain things you can do in Epic where it's called a ghost code. Epic, by the way, is an electronic health record that we use. I think it's probably still the number one electronic health record out there.
It is.
Today.
We have a lot of it down here too.
Okay, great. But you can put in a ghost code basically. So if you are that practice, as you mentioned, the scenario would be that, you want to do incident 2 billing, you feel good about it, that you have the right processes and protocols in place, that when that APP sees that patient, you would actually drop a ghost code in, and that ghost code then can be filtered out on the back end, and then you can give credit to the APP on a productivity basis.
So the ghost code would not go on the CMS 1500. It would go. Correct. Okay, I see.
Correct. It's just all in the background.
Got it.
Now we are. I think if I remember the latest literature and studies is that roughly about 50% of the country have APPs on like productivity models, and 50% have them on more salary model. Mm-hmm. We're on that salary model side of things. So at this point, we don't have to kind of worry about that. But as a leader, I want to start driving more performance and aligning kind of our APPs with our physicians. And so I'm forever looking at, when we turn this on, how are we going to credit the APPs? I said that we don't do incident 2, which we do not, but where this really comes up, Conrad, is in the inpatient world when you're doing like split shared billing, because again, you have to give credit to the APPs when they're doing that work. So.
Got it. And so we're going to get to split shared in just a second. I guess the question I would have is, if I'm a group, right, and I'm hiring APPs and I'm looking at comp models, what resources are available to determine salary based on specialty? Where does one go to look for that?
Yeah, I think probably the big three are AGMA, MGMA, and then the biggest one I think that we use is Sullivan Cotter, which is a consultant group, and they have something called the NAC, National APP Advisory Council. I really think Sullivan Cotter is really going to have probably the best, most robust data in the next couple of years that they've been working on it. And so what we do basically is we take kind of a blended survey of those three, and I think we might even have one more. And then we look at, salary information, productivity information, and that's kind of how we do our benchmarks.
Gotcha. I think that's, let me tell you, I can't tell you, now Spectrum's at a whole different level than a lot of groups down here. We don't have large systems like the two large systems we have down here are Ochsner and LCMC. But not like you have up in Michigan. So you have a lot of mid-size, large groups, in specialties, And sometimes you still have some small, medium-sized groups in this market. So it's a little bit different, but I know that there's challenges because a lot of these doctors want to hire mid-levels, and they're just scratching their head. Well, how do we do this? Especially if we want to do incident too. So that's a good. Thank you for those resources. That's really a helpful thing. Let's get the split shared now, because you mentioned split shared,
Sure.
and you and I actually had on our recent conference with Apex. You and I had a back and forth about this. So, tell me what is your understanding of split shared, and how does it relate to incident two, and why do you think it's important?
Yeah, so the way that we teach split shared, and again, I'll give a kind of a case study to kind of bring it all home, but is that we utilize this on the inpatient side of things, and it really, the term is really a misnomer, because when you think split shared, I think shared is what makes people get confused about this. And I go back to what we talked about earlier, which was the term around a test.
Right.
There's a lot of testing that goes on in the inpatient world, and that largely is because of medical staff bylaws. Because like here in the state of Michigan, we have to have physicians who see the patient every 24 hours, and so because of that, they are always attesting to what the APP saw.
Right.
And I bring that up because that's very important, because a split shared, again, is not just attesting. So the way that we teach split shared is this. You have an APP who sees the patient, right, and writes a note.
Mm-hmm.
The physician then comes behind the patient. And again, I'll give a case study on this so you can kind of bring it all together.
Okay.
The physician comes behind the patient and, can't just say, I agree with the plan, but literally has to do elements of the history, elements of the exam, has to be in the room, and then has to discuss the plan of care. And we teach it in a separate note. So we keep it completely separate. If those things are done and the physician sees the patient on the same day, which, by the way, is different than residence. This is where it gets, again, very complex.
Right.
That's different than residence. But on the same day, then you can do a split shared bill. So here's the example really quick.
Okay.
I've done many things in my career, but one of the things I did, my first love in medicine was orthopedics. And so, I would often come in and see the patient who maybe, fell down, let's say they fell down breakdancing, right? They're crazy 70-year-old and they're at a party and they fall down. Extreme hip pain, they're brought into the ER.
Right.
And the ER physician, calls me in. And so my job at this point is to see the patient, look at the x-rays, and, decide whether or not we're going to admit them, that sort of thing. I see the patient. I see on the X-ray, this is a definite, greater choke fracture, whatever you want to call it. But it's a fracture that's going to require surgery. Mm-hmm. I document in my note, saw the patient, did my exam. Let's say the patient has shortening of the leg and external rotation, all the things that we see. Plan to go to the OR in the morning, right?
Right.
The physician then comes in behind me, and again has to actually physically go into the room. Has to do the physical exam, so lay their hands on the patient. Now, what's a little bit nebulous about the split shared is that they really don't say, and maybe you can correct me if I'm wrong about this, but they really don't say how many elements you have to do of each. So it's not like you have to do 2 elements of a physical exam, or, it's just that you have to do an element of each one.
That's absolutely true in the Medicare benefits processing or claims processing manual. It doesn't say that. It just says that it has to be a substantial portion of the E&M visit, the evaluation and management visit. And you're right, that both the physician and the APP must be together, doing it together, whether that's the history, the examination, review of systems, the whole bit.
Yep. So again, that physician then is doing elements of the history, elements of the exam.
Right.
And then plan of care, and then they sign a note. And at that point, because we've met that requirement of doing it within the same day, then you can bill split shared, which means, again, essentially you're billing under the physician and giving credit to the physician. And again, this is where, if you are on a productivity comp model, we want to somehow give credit to the APP who saw that patient, just to give them something.
So they're going to document real quick, Keith. They're going to document that in the note, correct? I mean, so in other words,
correct.
From a documentation standpoint, you're having the APP document that physician X was in the room. I evaluated X. I did X. Physician in his notes going to say I was with APP so and so in the room, and I did X, Y, and Z. Is that correct?
That's correct. The physician has to be laying their hands on the patient. So let's go back to a testing really quickly. What you can't say is agree with APP's plan.
Right.
You can't say agree with plan, go to the OR.
Right.
You can't say I looked at the X-rays and completely agree. Go to the OR. It's like you literally have to write a note, and that's where I think the shared part gets a little bit. The naming is just a little bit of a misnomer because we teach it. You have to really be writing a separate note, having your own kind of clinical plan. You can say agree with the APP, but you still have to do elements of that exam finding in the plan of care.
And just to be clear, so everyone understands, when we say split shared, all that really means is, we're talking about the process of split shared, but it means we're billing that as an incident to claim. Is that right, Keith?
Yeah.
If we meet that requirement.
Yep. Yes. Now I don't teach it that way, but you're right. I always try to keep them separate, just to keep it very simplistic for people.
Right.
So again, this is just the way I teach it. The way I teach it is outpatient is incident to, inpatient is split shared, and you are right though. You really are billing then under the physician.
Right. You're getting the extra 15%. You're getting the 100% on that visit, on that E&M visit.
Yep, absolutely.
So that's a good explanation. I love the example. I think that's a very spot on example. That's a good way to see it. I know that the claims processing manual also talks about various settings. So, for example, you can't do it at nursing facilities or SNFs and critical care settings. But it does say you can do it outpatient as well. So it just depends on the setting. And as long as you avoid the SNFs and the critical care and the nursing facilities, you're going to be fine on the split shared. But let's go to the consequences, or really the fallout.
Actually, can I go back to the?
Yeah, go ahead.
One thing you just said that I think is an interesting point.
Go ahead.
You can do this on the outpatient side.
Yes, you can.
But here's what we teach, and I think some of the experts who are out there also teach it this way, that if you're doing a split shared visit on the outpatient side, I just want you to think about this financially for a second. So financially on the outpatient side, and I'm making generalities here, but on the outpatient side, right, these are people that are not like critically ill typically, right?
Right.
Meaning that, we don't need to make life-saving decisions, unlike on the inpatient world.
Correct.
So if you're tying up two providers now, so you have a physician and an APP who is seeing two providers who is seeing that patient.
Right.
Think about financially, that's going to be a no-win, right? So that's why we say we should not be doing a regular bout of split shared on the outpatient side, just purely from a financial perspective. Having said that,
right,
if the physician is needed, that there's something going on where the physician is absolutely needed, then absolutely go ahead and we feel comfortable doing split shared. But it should not be a regular practice.
So
and we still see
that's
this,
from a resource allocation standpoint, is what you're saying?
That's right. Because if you break down how much margin you make per visit, again, now you have two providers, which are highly paid, doing a visit for a person.
Right.
It should not be a regular practice. Again, there are some specialties out there that still do it and don't allow that APP to work top of license or top of competency. But again, financially, it just does not make a ton of sense.
And you're right.
On the inpatient side,
right.
It does make sense because that's what we have to do those things on the inpatient side.
Well, because the E&M levels are going to be higher acuity. So you're going to get higher level of reimbursement on, for example, a level 4, level 5, right? Than, say, a level 3 or level 2 on an outpatient side.
That's right.
So very interesting. Thank you very much for that. Now let's cross over the bridge to the danger zone, right? Let's get to the minefield.
Yeah.
So if you break compliance, then like in my example of the orthopedic practice that didn't do this for 3 years, suddenly you have false claims issues. And interestingly, you have an overpayment that, of course, the government's going to want that back. And each individual claim is subject to an FCA penalty of $5,000 to $15,000, along with a CMP, potential CMP, civil monetary penalty of up to $11,000. So you're looking at potential $20,000 penalty per claim. How many claims do you think get filed a day, Keith? How many claims do you think get filed?
You know, I don't. I really have no idea.
Over 10? Over 10? Over 100?
Oh.
You know?
Yeah, I mean, it's a lot. I would say, though, that, I mean, I think you're bringing up a really good point. It's not, think about this. It's not just like one auditor, like coming in and doing audits. Like, I mean, we have like OIG and revenue audit contractors and the HEAT team, I think, which is Healthcare Fraud Prevention Enforcement team, zone program integrity contractors. Like, so I bring it up because there are so many different forces, and their job is to find problems.
That's how they make money. I mean, RAC and ZPIC, RAC and ZPIC, the one you just mentioned, RAC and ZPIC, they don't get paid unless they find money.
That's right. And that's, I think, the cautionary tale here is, even if there is no intent to do harm or intent to do wrong, these organizations are out there along with our government, and they're going to eventually, it's going to catch up to you. They're going to find it. So that's why it's, you know, getting back to you asked earlier, like, why is it so important? That's why it's so important.
Well, let me ask you this. So your Spectrum has made the decision to not take the Incident to billing route, which I think, you know, compliance stand wise, it's a tough road to hoe. I mean, it's definitely a you have a learning curve. A steep learning curve. If you've never dealt with this before, if you've never heard it before, what would you tell groups based on your experience, your knowledge of this Incident to billing? What would be the best advice you would give groups who are looking to decide whether or not to do the Incident to or capture that 100%?
Yep, good question. So I would tell them this: if you decide that you know, maybe you're a smaller practice and you really need that 15% revenue, you got to put programs and things in place to make sure that you're doing kind of your own internal audit, to make sure that there's a system in place that really helps you to reduce that risk of involvement of those organizations that we just talked about. Because if you don't, again, it at some point it will catch you. So that's probably what I would say. Again, we made the decision not to. You know, I think that we had some pretty close calls at Spectrum that's been in the news, and, you know, nothing was found or substantiated. But, you know, when we started looking into this, it was like, this just is not worth it for us.
Right.
And then I was not in my role at the time, and I was just getting into my role. They were looking at me as to, you know, what are your thoughts? And again, going across the country and meeting with, you know, large leaders, and I think there's a lot of institutions, probably our size, that have also made that same stance. So just going to give you a little bit of perspective there.
That's very interesting. And again, if you're not up to speed on what it involves and how to set up an internal audit process for compliance purposes, agreed. You might be literally wading into a minefield and you just don't even know.
Oh yeah, and that's where they can probably use your services, right? Because you guys can probably set up like some internal audit stuff.
That's right.
Quite frankly, will be well worth the money, without a doubt.
Well, I appreciate that. Yes, we do. I wish a lot of times, Keith, that we would get the calls from the providers beforehand. A lot of times, I mean, I call myself Smokey the Bear sometimes because all I do is put out fires, right?
Right.
And if simply providers would just call and say, look, you know, because a lot of providers we know, and I mean, I know Rory can attest to this too, they hate lawyers, hate us. And like inherently, like, we don't like lawyers. All they do is bill charges, and we don't like them. Haha. So, but what I tell them is that we're literally aligned with you. You know, paying a little bit for our services now could save you a tremendous amount of money and headache, later. So,
absolutely,
it's just, but we'll try to shift the paradigm, to see if we can get that corrected down the road. But all these are fantastic points, and I want to thank you. Any final thoughts, Keith, to the listeners with respect to Incident 2?
Yeah, just final thought. I think you hit it on the head in terms of, I think prevention is critical. And we talked about kind of the benefits and risks. The 15%, I would just say, really cautionary tale. Is the 15% really worth it? In our case, it wasn't, but I understand there's different avenues and things out there that practices can look at. If you do decide to do Incident 2, please have an internal audit practice in place. That's what I would say.
Well, fantastic. Well, Keith, we thank you, everybody. Keith Hustak from Michigan. He is the Vice President of Advanced Provider Practice and Vice President of Operations at Spectrum Health. We thank you very much for coming on today. And I think that's going to wrap it up for us, Rory. Let's go ahead and close it out. Thank you, everyone, and we'll hopefully see you on our next episode of Health Law Talks at Shahardy Sherman Williams. Thank you.
Thank you for listening to Health Law Talk presented by Shahardy Sherman Williams. For more information or to contact us, please visit our website linked in the description below. Also, please be sure to subscribe to our podcast and follow us on Facebook, Twitter, LinkedIn, and YouTube linked in the description below. Thank you for listening.